things I usually see would include metastatic disease, and we talked about a variety of things that affect the bones other than the primary bone tumors, and then I'll talk a little bit about the primary bone tumors and the soft tissue tumors, and malignant and the benign ones a little bit. So we'll kind of go through a gamut of the things that I deal with. So one thing I learned in dermatology at the university, and people probably heard me say this, is that you got to recognize the really bad things and the really common things. Now, not that I can recognize any of those in dermatology, but I learned that principle. So there's a coral snake, and there's a little mnemonic for the red being on the yellow. That means it's the bad one, and not a king snake. And the coral snake antivenom is really hard to come by, so I really would not mess around with one of these. And then that's a garter snake. I saw one of those last week, and yeah, they're all over the place, and you shouldn't be worried about those. So it's kind of these principles apply. So we're talking about the rare, dangerous things, and it's valuable to have an understanding of that. The other thing, see, there's the red on black, and that's no venom, and that's. The other thing my dad taught me, he was an orthopedic surgeon, it's very hard to diagnose something you've never heard of. And that's self-evident, but that applies as well. So very quickly, we see a lot of destructive lesions in the bone, and most of them are metastatic carcinomas or myeloma, where breast and prostate cancer fit into the bones quite a bit. Prostate cancer tends not to destroy the bones 90% of the time, but we see a lot of renal cell carcinoma and lung cancer and breast cancer that are chewing up the bones. So I spent a lot of my time working with that as well. And we won't spend too much time on that because that's not our focus today. But we put a lot of metal in to reinforce them and get people radiated and rule out the primary cancers too through biopsies and imaging in part. So we'll talk a little bit about primary bone tumors. The big ones that we see are osteosarcoma, Ewing sarcoma, and chondrosarcoma. There's a few others that are much less common. And I'll talk a little bit about some benign tumors that also come up to imitate those. Poor Marky. I think he got released yesterday or the day before. I just saw this on that. So this is a patient of mine that I can tell you about because he had a press conference after I biopsied him, the day after I biopsied him, before the pathology was final. Based on my verbal relay of the frozen system.
A little nervous, huh?
I'm like, really? So, anyway, he's a principal linebacker. His dad is a high school football coach in suburban Philadelphia, and he was at Boston College, and he was an ACC Defensive Player of the Year as a junior. He had like 4 interceptions or something like that. And this was May. This was the month I finished at the University of Pennsylvania, and they just had the NFL draft in April, and they come out with, because no one's got anything better to do in May, and the NFL is relevant every week, right? That's how they keep themselves. So they had people talking about, well, next year, these are our projected first-round draft picks, and he was the number 2 linebacker in college football as of the moment he walked in my office in terms of draft order. So, fabulous. He had a big swollen left thigh. They'd been getting chiropractic treatments on, and I don't know what else they were doing. But he had a massive diaphyseal tumor that I was almost sure was going to be Ewing sarcoma, and unfortunately I was right. So I did a little open biopsy, got a little tissue, and kind of talked to his parents about that, and then he had a press conference the next day, and he started chemotherapy and did the whole thing. But boy, I was sure glad when the final pathology came back and it was the same. So now there he looks like he's 12, and he's getting the Courage Award, for going through chemotherapy. Not as though it was an elective thing to do, but that was kind of funny. He had a prophylactic nail to his femur after getting radiation, so he did not have his tumor removed. The big soft tissue mass shrunk down thanks to the chemotherapy, and then he had radiation, and he had a nail reinforcing it, because otherwise he would not have been able to run very well. If I took out the whole femur and did an allograft. Those heal really slowly. We don't really want people pounding on that, and you kind of have to baby the leg a little bit. And certainly was not going to go back to for his senior year. So he missed a year of football, went back to his senior year, did very well again, but he was undrafted. He was signed by the Giants, and he got in some games that first year. His best year was 2014, and that was his first year. He got a ring. So he had a Super Bowl ring after as a year one player. He's still lucky. But yeah, he played. I don't know if he's going to retire, but he was just released this week. I saw, and I've never really. I'd like to talk to him again. I haven't really talked to him much since he was in the pre-op holding area before his biopsy, and after having had this really tough conversation with him and his parents the day before, so he wasn't super chatty or friendly at the moment. But anyway, so that's a story that's great because I love telling my patients, well, the patient's in National Football League for 7 years with a Ewing sarcoma, so we're gonna treat you with great optimism and high expectations, and let's go get after this. So it's not even giant tumors in young people with a lot at stake can have good outcomes. Not all of them, but it's possible, and I think it's a good thing for patients to focus on. So, and that illustrates some principles too. We tend to do open biopsies. We tend to do chemotherapy up front for the bone sarcomas, and then surgery, and then more chemotherapy typically. And the Ewing sarcoma is one of our few sarcomas that's radiation sensitive in the bone side. So we'll go through these quickly. The osteosarcoma is our most common thing. It tends to be in the distal femur in younger people. So is where we'll see it the most. There's a few things that can cause it. We've talked about radiation causing tumors, and some other conditions that can cause secondary osteosarcomas. And you got to take it all out. It's not radiosensitive enough that we can terminally radiate it. And well, I suppose you could kill it with radiation, but you'd kill everything else in the leg too. You know, there's some limits there. But we tend not to do radiation because it doesn't add much chemo. This is one of our great chemotherapy success stories, really, and you hear more about that. But I usually tell people that before chemotherapy, if we had an amputation the day you meet the patient, the survival rate's about 19%, and now it's pushing 70, 75 to 80% in the best of cases. So you think, well, 20% of those, 19% of those people didn't really need chemotherapy because they didn't have metastatic disease already. But gosh, that means 80% of the people already had metastatic disease when they showed up. That's no good. And there may be 20% of the patients or 30% of the patients that you can't help no matter what. That means you're saving 50% of them with chemotherapy, and that justifies giving it to everybody. That's a really high batting average for such an aggressive tumor that has such a high rate of metastasis on presentation. So this is one in the shoulder, up at the humeral head, and these are skip metastases, which have kind of very similar prognosis, distant metastases. That's not a good behavior. So that was a bad behaving one. So this is the little scary X-ray you will see today. There's a very subtle periosteal elevation in the lateral aspect of the femur, and that is a classic osteosarcoma finding. A little extra density in the bone. Really easy to miss in a kid with kind of a sore knee. And that's the Codman's triangle, and that's the bone, the tumor permeating through the bone, and as it blows through the bone, it'll lift up the periosteum, and the periosteum's job is to heal your fractures, and that's its number one job, is to form bone. And so if you irritate it, it's acute to form bone, so it's trying to do that. It's been irritated, it's forming bone, but it's telling us that there's something going on there that we ought to pay attention to.
So we all know it's this part right here.
That's a bit right there.
This subtle part.
Yeah.
You can imagine if you're just looking for the knee in your emergency room, you're just going to bypass.
Just zoom like,
There's nothing wrong with the knee.
Yeah, no fractures, no cracks.
Yeah,
Yeah.
I saw that little thing.
I don't know why it's hurting you. So, it's not the exact same patient, but a classic distal femur presentation with the bone the tumor starting inside the bone and then extending with it outside the bone as well. And here's a real giant one in a giant guy, you know, bone-forming tumor. This is more than just lifting up the periosteum a little bit. The tumor is actually forming bone. This is a huge lesion outside the bone and in the marrow, even above and beyond the soft tissue mass. So I spent a lot of time looking at MRIs and X-rays and squinting at them and thinking about all the other tissues and what's got to go and what can stay and where do I need to cut and how am I going to reconstruct this and how long is the surgery going to take and how long is this prosthesis going to last. I think about that, and I usually think about that usually before I meet the patient. I have all my surgery planned and I've decided what it probably is. So that's kind of I go through those exercises a lot. So that's distal femur replacement with a rotating hinge total knee, which is actually this guy I think had a total femur. He lost his whole femur. But that's the big metal implants. That's what we do for the bone sarcoma. So Ewing sarcoma we've talked about a little bit. Still a little fuzzy on the cell of origin, but chemotherapy before and after, surgery if resectable. The osteosarcoma really likes the proximal humerus, the distal femur. Those are the areas with the most active growth plates. Proximal tibia, the ends of the bones where there's been a lot of growth. And you think, oh, those are somehow related. Yeah, probably. You know, there's a lot of growth. There's a lot of opportunities for something to go wrong there. So that's one of the factors we believe. The Ewing sarcoma can occur in the middle of the bones. It's a little. It is more often seen in the pelvis and in the spine, and these are much more inconvenient places to do a nice big surgery and replace the bone with a metal part. And fortunately, it's more radiation sensitive, so a lot of times we use radiation in these areas where it's hard to get a positive margin without sacrificing an organ or a spinal cord or something like that. So that is Ewing sarcoma. There's this little blip in the middle of the fibula, and that's not really an osteosarcoma spot. They like the ends of the bones. And then there's a giant soft tissue mass associated with that. So it's not a bone-forming tumor, but this is a little more typical, or I say more distinctive appearance that you would expect out of Ewing sarcoma in many cases. So, and then under the microscope, small round blue cell tumor, no bone forming. So these things look very different when we're doing our open biopsies, and that allows us to give these preliminary diagnoses with some degree of confidence. All right, chondrosarcoma is a cartilage-based tumor. Now, they're no fun. Dr. Okun doesn't like chondrosarcomas because they don't cooperate with the chemotherapy, and they're not very sensitive to radiation either. So, really, it's all on me. And because I don't have those backups in case I get close or I kind of get into it, we have to be really aggressive the first time around. If you get recurrences of these, they're very hard to treat. All right, so this is again a super subtle. Permeative lytic change here, and you say, is that even abnormal? I don't know. This is a dialysis nurse that was in a car accident, and they diagnosed her with frozen shoulder 6 months later when her arm started to get more and more stiff, and the therapy wasn't working. And this is her MRI that they finally got. She's a big extra soft tissue mass, and then a lot of tumor inside the bone. So we took all that out, and she's. This is done in my fellowship. You notice the absence of the shoulder blade as well. So they really went big. They thought the joint was probably contaminated, and they wanted everything out of there. She doesn't have any shoulder function. She can do elbow, wrist, and hand a little bit, but this doesn't give you shoulder function. You say, well, isn't there like a shoulder replacement? Or yeah, you can make a big shoulder blade out of metal and try to sew it to the muscles of your back. And it doesn't work all that well, and they weren't willing to try that. So there's some places we don't have fabulous reconstructions like we do for the hip and the knee. So, here's another type of chondrosarcoma growing off of a surface bone tumor called an exostosis, and this is the area of cartilage. And we say, well, these have a little cartilage cap, and if it's bigger than 2 centimeters, it's usually malignant. Well, I can tell you from the x-ray that's about 5, 6, 7, 8 centimeters, so that was going to be more. All right, myeloma, I won't talk about too much. It's a bone marrow cancer that we see a lot of. It's kind of in the same category as the metastatic disease. It's very destructive. And we wind up doing a little cement and rebar for these. I do mostly plates now, but that's another one with a lot of bone cement in the middle and a nail.
So a question.
Yes.
Is myeloma totally distinct from sarcoma then?
Yep, it's a let's see, the orthopedic, the simplified orthopedic version of this, and people can correct me if I'm wrong, it's like a well-differentiated lymphoma. Okay, because it just has the plasma cells in there, so,
So you
but
take out.
myeloma is nasty. I see a ton of myeloma. It has an excellent 5-year prognosis and a terrible 10-year prognosis. The recurrences, it seems to always recur. Autologous bone marrow transplant is what you're going to get if you can tolerate it. But I am super biased because I only see the people who have really bad problems and multifocal disease, and their bones are all like dissolving out from underneath them. So I'm very cynical about myeloma, and I don't know if it's really curable, and I see people who have terrible problems, so I have a bad attitude about myeloma. And I don't like to diagnose it because I just think, oh my gosh, this person's not going to do well ultimately. And now the thing I like about it is it's very sensitive to radiation. So we can take it, we can deal with it at the shoulder. I can zap it with radiation, and then it won't recur. Very unlikely to recur, at least. One of the challenges with radiating every bone that it comes up in is then your available bone marrow starts to drop off. And so the medical oncologist will really say, well, we try to be really careful radiating all the ribs and the spine, which is in the pelvis where all your bone marrow is being generated as an adult. So there's all these trade-offs.
Mm-hmm.
But anyway, that's my.
Why do you bring that up?
My mom has multiple myeloma.
Yeah. So
I would just go back to that myeloma part. When we trained, the only thing we had is a double transplant.
Yep.
So you give them chemo, you collect the harvest, you transplant them again, bam, 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 in a
Yeah, a
row.
little fluidamide, a little steroids,
Right.
and crush your fingers. Right?
Now,
Yeah.
we have such more effective therapies that you don't even need to transplant some of those people
Yeah.
because they do well for 10 years, plus years, with simple medicines now that you never had before.
Yeah.
Now what happens is that he's seen them after 10 years of treatment and they now had other problems, and then that's not just one bone, it's a lot of bones. But we have a lot of people that have done a long time.
Right. So I'm the end of the line for some people. I see the small percentage of people who have recurrences and have recurrent problems. And so I see that. And this is what I said, very biased in the patients
I
I
was
see.
just curious.
But having said that, if you say I come to you with a shoulder problem, I can fix that, and your shoulder is going to be fine.
Mm-hmm.
It's just part of the big picture if you're having recurrent problems. All right, we won't spend too much time on the benign tumors. There's some fun and interesting ones in here. Osteoid osteimas are little teeny tiny tumors that form bone, and that's the little itis of it. They're usually a centimeter or less, and they're super painful. But you can take like a half an aspirin and the pain will go away. They're very distinctive tumors because they make the exact chemical that's blocked by anti-inflammatories. So they're interesting that way. Osteochondromas we saw. There's a speed bump shaped one in the ankle. We saw that big one on the pelvis that looked like a big head of cauliflower. That's some more mushroom pedunculated shapes. Yeah, kind of like this thing coming off the back of the tibia here. So these are surface bone tumors. We think there's an error in the growth plates, especially the edge of the growth plates and how they form. And they can. The simplified way of thinking about it is a little bit of growth plate gets left behind and just forms a bump on the side of the bone. And there's a genetic condition where people will form hundreds of these, and they are more prone to have chondrosarcomas. There's another condition that can give you sarcomas. So we have to watch for that. Now this is funny. Okay. And chondromas are little cartilage deposits inside the bone. There's one in the finger. It has a hole in the bone. The bone's a little expanded, and people can fracture through these. They generally clean them out and graft them if they're having trouble. There's another condition, multiple enchondromatosis. If you have lots of these, those people have a very high rate of developing sarcomas, the cartilage sarcomas, the chondrosarcomas. All right, there's a little enchondroma, a little subtle calcification of the bone marrow, bigger on the MRI, but nice and benign. only see these on the bone scan. Alright, and there's one in the femoral neck on the left. And someone who's also got transient osteoporosis. Yeah, now these can become sarcomas, and when they do, the little calcifications that have been getting more and more and more over time, they start to melt away. So if we get serial x-rays of these people, and you say, oh, you're losing calcifications, that's a really bad thing. That means they have chondrosarcoma. So sometimes when these change, you think, well, is it your hip arthritis? Or, people come in with pain, and we're trying to sort out where is the pain coming from. So there's a lot of my time doing that. And you think about the anatomy, you look at the abnormalities on the x-ray, is it a possibility? And then you pursue your diagnostic work further, and that might be an MRI, and it might be a biopsy if you really can't come up with an answer. So, and this is what our message to the primary care doctor. So, if you have a lump, follow it up, pursue it. You need to have a story that makes sense, and I'll circle back to that. And bone pain, you really want to keep up with that. You think, well, gosh, if somebody comes in and think, oh, they're swollen, did you have a fall? This looks like a bruise. Well, no. Well, how long ago was your fall? Well, I don't remember a fall. This looks just like a bruise. Well, come back and see me later, and you really want a good history, and you want everything to match up and make sense. And if it doesn't, you have to keep after it and pursue the diagnostic routes. Anyway, so that's an achondroma that turned into a chondrosarcoma, super rare.
Can you explain the timeline for a growth period and what you should see?
Yeah, and people have tried to get at that by asking patients. There was an article published this year, big article about asking patients how long they had symptoms, and it had a really hard time correlating that with outcomes, but it's not super reliable either. When we look at patients, it's not common for people to have a soft tissue sarcoma with that's growing with a history of more than a year or so, and usually it's in the months range. There's a few exceptions. A synovial sarcoma, people say, oh, I've had that for 17 years, it just started to grow and hurt me 3 months ago. So synovial sarcoma is one of our least favorite sarcomas because they can imitate a lot of things, and their behavior is a little atypical, they hurt a little more. Now they might be a little more sensitive to chemotherapy, so that's good. But all these things have little personalities, but mostly it's in the months that you'd expect something to come on, and it's really hard to know exactly how long something's been going on though. So all right, now that's fibroma. I'm not going to talk about that because those are super boring and they go away by themselves. And solitary bone cysts, usually in the proximal humerus. Very annoying, we don't know very much about them. They tend to resolve, but they can result in these fragile bones right when kids are wanting to play sports. So, giant cell tumors and an aggressive tumor that we'll see in the ends of bones, typically in the same place as osteosarcoma. So the end of the femur with that active growth plate, there's just a lot of different tumors that will wind up there for the reasons I mentioned before, we believe. So there's one, replacing the end of the bone, the marrow space and the end of the bone right up to the joint space, really weakening the bone. That's a super inconvenient spot and hard to restore that bone. All right, I'll talk about major. So soft tissue sarcomas, we'll talk a little bit more about those we talked about. And this has already been talked about, will be some. I'll kind of skip to we've talked about the deep masses. There's some rule that I keep trying to find the reference for it. It's been said that 50% of the mass is greater than 5 centimeters and deep to the fascia are cancerous. So once it gets a couple inches, we really start worrying about it. The MRI appearance is very nonspecific. So on the imaging of the bones, I said, I can almost tell what that is, but without even biopsy it. And that is the case with many of our bone sarcomas. Not so with the soft tissue sarcomas. Most of them look pretty similar. The fatty tumors have a little fat. MRI is great for picking up fat. That's one of its virtues. But if you don't have fat in it, then it's like, okay, it's a big something. Who knows what it is? Any of our dozens of possibilities. So I do a lot of needle biopsies in clinic. I did one over at Regents Hospital on Tuesday in clinic. I did a needle biopsy. I think that was my last one that I did. I use true cut needles and make a 1.5 millimeter incision, and I try to be sure that I'm not going to hit a major vessel or nerve, and that's the MRI is your guide for that. So I tend not to like to do them without an MRI. and they are very effective, and they kind of move the treatment along if you're able to do that in clinic. So there's many publications that describe that. The other type of biopsy would be an open biopsy, where you make a small incision, you take a little piece of the tumor out. I described doing that for the bone tumors, and you can certainly do that for the soft tissue sarcomas. If I have a big tumor that has a nerve bowstrung over it, I might want to do an open biopsy, or if there's a vessel in the way, sometimes I'll do that. And also the people with neurofibromatosis that get the malignant peripheral nerve sheath tumors, the tumor is really coming from a nerve. It's the nerve fibers that are becoming tumorous. Those would really hurt to biopsy. And so I've done a couple of those in clinic, and I think I'm kind of done doing those in clinic. Sometimes they don't hurt, but the ones that really were painful for people were not a great experience for anyone involved. So I tend to do neurofibromatosis patients with some sedation, and that's let's see, it's kind of a gentler way for me. Anyway, so excisional biopsy. This is one of our great problems and challenges. People say, a lot of these tumors have little pseudocapsules and they just pop out. It's really easy to take out. So it's not a technically difficult thing to remove the tumor. However, you ink the margin in pathology and they say, well, you got ink right on the tumor. So that means there's some tumors left behind somewhere. But now I can't see the thing. And if you didn't do an MRI beforehand, where is it? How extensive was it, and what should I be taking out? Because the next treatment is to go do what we call a wound bed excision, because we'd like to have a negative margin surgery. And the reason is that for all our advances, I'm still in business. Okay. In other words, the chemotherapy and the radiation is not going to completely eradicate all the soft tissue sarcoma cells in every case. So the batting average of that's not high enough for me to just move on and do only joint replacements and not have a job anymore. So I got to go back and take a little bit of the tissue, but boy, if I didn't know where it was, it's really harder. And then I think, okay, this was a high-grade tumor, it's a young person, I really got to be aggressive, and I'm going to do a free flap, and I'm going to take a big chunk of muscle, and then, the functional, the long-term consequences of that are starting to sound less attractive all of a sudden. So it's almost better for people to go down and look at the tumor and say, well, I'll just take a little piece out, and then the radiation, people have a better target, I've got a better target. If you didn't happen to get an MRI ahead of time, we can kind of see what all tissues are involved. So many people say, well, it hurts, it's got to come out sometime, so we'll just take it out. And again, super easy to take out, not the right thing to do because it can have functional consequences. And even for the bigger, deeper tumors, there's prognostic consequences. People put drains out through tissues, and the tissue contamination is very, very hard to control. There is some evidence now, and it's taken a while to really make that clear, that if you have a local recurrence of a soft tissue sarcoma, that will affect your long-term prognosis. And then you think, okay, that kind of makes sense, and many of these don't metastasize, so that it's been a little hard to demonstrate clearly, but that's come into focus a bit more. So if you put someone at risk for a local recurrence by having lots of soft tissue contamination that's hard to account for, then we believe that will affect their long-term outcomes. All right, tumors and the radiation therapy. Since they're tumors, and the ones that are not, and that we just shouldn't bother, I just go and take out right away. We're not quite there on these things, but as you saw from the grading system, that there are characteristics of the tumor other than what name we want to hang on it that have to do with prognosis, and ultimately we believe we'll be able to fine-tune treatment based on some of those features perhaps yet to be discovered. So getting it all out is still the expectation, the gold standard for soft tissue sarcomas. Since Dr. Duesenberry is not here, I get to opine on radiation without anyone correcting me. So, now having said that, I am the most radiation compliant person in our department. I always do with the radiation oncologists say. And in soft tissue sarcomas, the big controversy at one point was, well, it still is, do you radiate them before or after you take it out? You radiate that area. And what's the purpose of radiation? The purpose of radiation is so it doesn't regrow, and found out that that decreases the local recurrence rate. So you tend to radiate the tumor and then 5 centimeters beyond. And if I've already taken out maybe the field and 5 centimeters beyond, and then one of the ways the radiation works is it actually creates a large oxidative stress on the tumor. So you got to stop taking your vitamin E and your vitamin C, you know, antioxidants, because we want to oxidize the heck out of the tumor. And you know, it creates almost the same way your body kills bacteria. It creates superoxides, and then the object of those is to create a double-strand DNA break that will kill the cell. And so we radiate people over 5 to 6 weeks because we want to catch every one of those cells with the histones off, trying to divide, right? And this one could be attacked by the oxidative stress that you're imposing on it. And so you're getting radiation 5 days a week for weeks on end. And you first go in, and they do a little simulation, do a CAT scan, they decide where the tumor is, and they design their field, and the computer thinks on that, and then they have to decide which direction the beams are going to come, and what shape they are, and how strong they are. And I don't know how they decide that, but one of the things they do, especially in the lower extremities, is you want to spare a little strip of skin, because the radiation is going to really cause a lot of sclerosis of the lymphatic channels, and you're going to get some edema if they're circumferentially all wiped out. It'll blow up the leg or arm. So they're really trying to spare skin if they can, certainly a whole strip of soft tissues if they can. They like to spare the bone if they can, because the radiation will kill the bone too. And then you have the dead bone. There's only a few osteocytes there that are still alive trying to maintain the bone. You get microfractures in your bone all the time. And if there's not enough living cells to maintain the house, one of those cracks is going to lead to a fracture. And then guess what? You fractured through a dead bone that doesn't feel like healing either. That's a big problem. That's a real nuisance for me. So radiation is great, but it has some side effects that we try to control in part with the field. In part, it might say, I got to strip all your periosteum, which we already decided its job to form new bone. It's going to be gone, and then I'm going to blast your bone because you had the tumor wrapping halfway around it, and you didn't want amputation. We thought we could spare it. The deep margins are almost a tenth of a millimeter thick, so they're cell wall thickness there. And so I'm going to put a titanium nail down your leg because you're at high risk for fracture 10 years from now. So we do things to try to mitigate some of those radiation problems. But anyway, the pre-op and post-op radiation, the big deal when they did they did a randomized study where I did my fellowship just before I got there, and they found that for the post-op radiation, the wound complication rate was 17%. For pre-op radiation, it was 33%. And they stopped the study, but they still do pre-op radiation there. and you think, well, wait a minute, your wound complication is horrible. Why? How can you possibly? Well, it turns out that you give a radiation dose to a smaller field, and you give a lower dose if you do pre-op radiation. And if you ask the radiation people every time, that's what they're going to want to do: give the minimum dose to the smallest amount of area. It's not even a point of discussion for them. They also don't have to deal with the wound complications. I have to deal with that. But the wound problems get better. Okay, and some people, they have to go back to the OR, and it's scarring, and it's a pain, and it's a long-term dressing changes, and it's a huge nuisance sometimes for a long time, but they will eventually heal. If you have chronic edema or muscle fibrosis from your dose got a little too high, or they had to radiate a little bigger area, that can get even worse over time, and those sometimes don't get much better. So it's a trade-off. It's a point of discussion. Now, it's very different. If I'm having to protect a big metal implant, I cannot tolerate it, because then you'll wind up getting infected and you'll lose the whole extremity. So I have to balance those out with, can I handle a wound in this area or not so much? So those are some of the things that we talk about. But just to finish the what things are like, after you do the planning, they build a little jig to hold your arm or leg or shoulder or whatever, and then one way to think of it is it's connected to the machine, so the machine knows exactly where your deltoid tumor is. When you lay down, they get you all positioned in there, and sometimes they can recheck that with a little CT, and they have the bone landmarks. They put little tattoos on you So they line up, okay, everything is where it should be, zap, zap, zap. External beam radiation, used to be they could give 3, maybe 4 beams, and then they came out with intensity modulated radiation therapy, IMRT, and they had big billboards up, and I don't know if it's any better for sarcomas, but it was definitely marketed as though it might be. And then Dr. Duseberry is doing a gamma knife, and she said something having to do an 8-1, and it changed into an 18, and I didn't know what she was talking about, but that means it's much bigger. So that you have more like 150 beams, and you can really say, well, with 150 points, I can really sculpt that high dose field however I want. Except I got 150 beams, which means it's very hard to not hit some area. You know, everything's going to get radiated to some degree. So if I want some area with 0 radiation, I out of luck with that. So we don't use the gamma knife with soft tissue sarcomas because as much as I've complained about the bone, it can handle a lot of radiation. Muscle's very strong, it can handle a ton of radiation. Skin will do okay ultimately, and the nerves are not too bad, and the vessels. Bowels, they don't tolerate very well. Lungs, not very well. So most of the extremity tissues, yeah, you know, as long as I leave a little strip for some of the lymphatics to be okay, it's not such a big deal. She's, you know, in the brain, they're trying to really spare these neural tissues that, again, have a big impact on function. So they've developed a means to do that. There's other forms of radiation where the particles, instead of going straight through, we can kind of stop them on a dime. So that'd be really helpful if I'm radiating your sacrum from the back, and I don't want your large bowel to get all the downstream radiation for that. So there's some applications, and there's some new forms of radiation. The carbon, I'm not really clear on the applications for that. I think I may not be alone there. But there's various forms of the radiation itself it has a very similar effect, but the ways to deliver it, there's some different flavors there other than just the external beam radiation, electromagnetic radiation. So, all right, so let's see if we life and what have you at risk. Hard to enroll people in that type of investigation. So here is undifferentiated pleomorphic sarcoma, formerly known as a malignant fibrous tissue sarcoma. But this is a very nonspecific appearance, a very muscle density like tumor on a T1 imaging, on a T2 they're kind of bright, but with the mixed signal, very nonspecific. This is what most sarcomas will look like. And very cellular, lots of different oblong, funny looking cells, some really giant nuclei, and they're kind of ugly looking, but there's it's not really clear where this tumor comes from. There's no background matrix. It says, oh, this looks like a skeletal muscle or a nerve. So you see all different sizes and shapes of the cells. All right, synovial sarcoma, this is the tricky one in my view, in part because they can calcify, and so they might look like myositis. They actually don't come from the synovium, so they have a bad name. I see them a lot of times in extra compartmental spaces, which is more difficult to control your margins if you're not like in a muscle or something like that, if you're in between the muscles. They are often cystic, and if you're periarticular and cystic, that's a ganglion cyst, right? But they could be cystic as well. The most common tumor in the hand and the foot, surgeons, some of which are podiatrists and have a slightly different training than you all are going to get. They have even less appreciation of some of these rare and weird things, and a number of people had those things. The synovial sarcoma was popped out of their foot by someone who's never heard of synovial sarcoma. So there's one in the right upper. It looks like a Pancoast tumor in the lung, right? But it's really a calcified tumor in the paraspinous muscles, and it's turned out to be a synovial sarcoma. But it could be myositis, I guess, or maybe even a surface tumor of bone. Who knows? Kind of big differential for that. But that was an inconvenient spot. And then you look at these spaces, and they look like they're lined by epithelium. It's like, you sure this is not a carcinoma or something different? So some of the synovials can have epithelial type of formations. And this is one of the tumors that we think can get into the lymph nodes a little more than the average sarcoma. Although I just read a paper that said it was maybe not as much as we think. So that is a synovial sarcoma. That is a very inconvenient synovial sarcoma that looks like a paralabral cyst in the shoulder. very cystic tumor. So this is a contrast study. And the contrast study is what we're looking for is this is the mass. It's not picking up contrast, but we have a little rim that's highlighted. And that's classic for just any cyst, for an abscess, for a ganglion cyst. Rim enhancement is what we're calling it in the contrast study. Now you say, well, you have this nice septation here, and you really need to scroll through the whole thing and see if you really get an enhancing mass-like area somewhere, and this person did have it. But if you just look at that, going right up to the joint, you think, oh, he probably has a labral tear, and he's got his big paralabral cyst. It's bigger than average, but you know, those happen all the time. Super duper inconvenient spot to get out. Fortunately, he had, I think he had chemo and radiation beforehand, so I had like 6 months to think about it. Now, here's a guy who looks even worse. You say, well, he has a thicker wall. I'm even less comfortable with that. Well, this guy ruptured his biceps tendon and bled into that area. But he had a great history. He said, well, I went to open the door and I felt this pop and my arm swelled up and got black and blue. By the time he saw me, the black and blue and the swelling had gone away. And then, you know, he got this within days. And I said, well, the day before this happened, did you have a mass? No, completely fine. And then, you know, and he's got the contracted bicep, he's got the Popeye muscle from ruptured bicep tendon. So his exam fits, is a very nice history. Everything fits very nicely into an injury. And if you're really worried, could you biopsy this? Could you re-imaging? Sure. But he has a really classic history for something else. A very sudden onset with black and blue and a fabulous story. And so then you say, okay, I'm comfortable with that. We're going to observe. But somebody comes in like that and said, well, you know, again, you know, when did you hurt yourself? I'm like, I don't know what you're talking about. So then you have to pursue that. Okay, liposarcomas we talked about. I won't go on a rant about the nomenclature. That would take too much time. But other than to say that there's people who, and I saw a lady, I think the lady biopsied at Regents, she had a couple other superficial lipomas and then had a big deep one now. There are some close cousin to the lipomas, the atypical lipomas, which some people call well-differentiated liposarcoma, even though they don't metastasize. So this is fat in the bone marrow, fat in the subcutaneous tissue, and this is not fat. So this is the yin and the yang, the good and the evil. This is dedifferentiated into a malignancy. So that the fatty tumors can change from kind of this benign appearance to cancerous appearance, some of them. And that's something we can see. You can see very well in the MRI. Like I said, fat really jumps out and is very distinctive on MRI sequences. And so there's a tumor with fat in it. Now, there's some benign versions of lipomas, some of the lipoma variants that could look like that, a spindle cell lipoma. But this one, that's a liposarcoma, until proven otherwise. You need a biopsy. You need to biopsy this half, please, not that half. And so the imaging can you direct, as I say, can keep you out of the structure you don't want to injure, but also you can say, oh, there's a big cyst over here. I might not get so much out of it. I'm going to go over here where it's more solid, and I'm going to pick a place that is going to be higher yield. So that is a lipoblast there. All right. So it talks about we consider these tumors for masses or pain, and this is kind of the message we try to get out to everybody. Now, a lot of people have pain, and a lot of people have lumps and bumps. So things that come on in a few months, they're not going away quickly, and you ought to have a story that fits together. So if things don't fit, you got to pursue things, and pursuing things might be, I want to see you again in 6 weeks. You know, just I want to make sure this goes away, or I'm going to have my nurse call you, and you know, in 2 weeks, and if this is not better, we're going to get an X-ray or whatever the case may be. It's staying with something, and that's also working off a differential diagnosis as part of that too. And that's something that you guys learn in medical school, and then we kind of forget a little bit sometimes. I have people calling, describing something, and I say, well, what do you think this is? What are the, you know, we're trying to make a decision, but we haven't talked about the possible diagnoses. And then if something bad is a realistic possibility, something cancerous is on the list of possibilities, then we don't want to miss it when we pursue that with the further diagnostic workup. So for soft tissue mass, it's an MRI. And then and then this one that always kills me too. A lot of people who you take these masses out and they turn out to be a synovial sarcoma and say, well, what do you think it was? So what, I knew it wasn't a ganglion cyst because it didn't transilluminate, and I tried to aspirate from it, no fluid came out. But that's what it wasn't. What did you think it was? Well, it was bothering her, and I thought it needed to come out. Okay, all right. So they didn't actually think of it in terms of what might this be and what's the right thing to do. They're thinking, well, I can't figure out what this is, and it's bugging this person. Maybe I should. I'm gonna help them out, take this out, and that's not quite the right way to think of it. So, all right, thank you for letting me go on and on. What questions do you have?
And the physical exam, what is the
A
thing
lot.
to be worried about?
A lot. And one thing we didn't touch on, and it's not a huge consequence, but how do you determine if something is superficial or deep? And you say, well, the superficial things are less dangerous, but so if you have somebody flex the underlying muscle and it goes from being mobile to all of a sudden like, man, I can't move it, that means it's adherent to the muscle or muscle fascia, at least, maybe inside the muscle.
What's the name of that? I use that today.
Or if I'm really active and the blood gets in there and then it might come back down. So inflammatory things can do that, cysts can do that. Malignancies, any self-respecting malignancy is not going to retreat. Once it gets to a certain size, it's only going to get bigger. And, that's true for most benign tumors as well. So there's not a lot of things that will shrink down in size. Injuries do that. That's what you want the hematomas to do, right? You want it to resolve.
The only thing that you would say is that desmoids,
Yeah.
aggressive fibromatosis, 20 to 30% will shrink spontaneously.
Yeah.
So those you don't want to overtreat as well, even though they're neoplasm, they're not a malignancy. So just to kind of keep that in your mind.
Least favorite benign.
That's the other.
Desmoids are also.